I had one kid that was at that point like a month and a half old, and the kid was having all sorts of problems feeding, and would feed for such short periods of time. Was being treated for reflux. They weren't sure what it was. They saw me, and I can't even remember the exact complaint. I think that it was being interpreted as difficulty swallowing. For whatever reason, it wasn't presenting as classic tongue tie, just latching difficulties. And so in the process of my evaluation, mom had been getting no sleep. So you know how frayed you can be from getting no sleep. And this was a month and a half of mom getting no sleep because kid was just couldn't feed for that long, and then would wake up again and not feed for that. And she was just at her wit's end. And in the course of my evaluation, I noticed there was a tongue tie. So I said, you know what? I don't know if this is it. I don't know. Could be. Maybe. Maybe not. And I cut it. Kid fed. Mom was crying because it had such a profound. She's like, this is the longest she's ever fed. This is the longest she's ever fed. This might be, I don't know if this is it. I still don't know if this is it. We'll check back in a couple of days. And I called her a couple of days later, and she was just so effusive because like I had, turned things around so completely. And it was just because, what did I do? Stuck my finger onto the kid's tongue, cut the tongue tie with a little scissor, and that was it. So, so that's the type, that's one thing that we see very commonly, tongue tie. It seems pretty simple and pretty straightforward, and it is, especially in a 4-day-old, right? The way that I do it is with a scissor. I just stick my gloved finger, underneath their tongue and snip it with a scissor and have the mom, I don't numb it so that they can breastfeed, because the main reason to do it is if there's difficulty breastfeeding. Kids having some trouble latching, they're not latching, it hurts too much, mom's nipples bleeding because the kid's not latching correctly. And it's, it's a couple second procedure, and then you have mom breastfeed straight away. It calms the kid down. It pushes the tongue down so it stops any bleeding, and then they're breastfeeding, and it's great, and it's very simple. And again, this is kind of like what the specialty is for me. It's simple, it's easy, and the outcomes are life changing. Now mom can breastfeed. She wasn't able to breastfeed. She thought she wanted to, but she thought she was gonna have to go on. The kid was gonna have to go on formula, and which is fine too, right? But they now have this other choice available to them.
Hello, welcome to Medical Murmurs, where emergency physician Dr. Paris Lovett talks with other doctors about their lives and their work in medicine.
My guest today is Dr. Bradley Block, ear, nose, and throat surgeon who sees adults and children and is based in New York. He's also the creator and host of the podcast, The Physician's Guide to Doctoring. Welcome.
Thanks so much for having me.
Thanks for coming along. So I always like to start by having you tell me a little bit about not just your background in medicine, but in fact, a bit about you growing up, your story.
Oh, interesting. My story, I think of as the opposite of interesting. I grew up as on Long Island, which is where I ended up, where I practice now. The suburbs of New York City, a somewhat diverse town. Although Long Island, one thing it's famous for is its lack of diversity, or rather, being very segregated by both religion, like race and religion. But my town happened to be pretty diverse, both ethnically and economically, which was obviously a great experience growing up and very important. Upper middle class upbringing. Didn't really make the decision to go into medicine early on. We didn't have any physicians in our family. But always very into science. And when you're into science, I don't know how many options you really realize are out there. So when I was studying abroad, one of my friends, he was going into medicine, and I thought, hey, that sounds like a reasonable thing to do. I don't have any other ideas right now. I know everybody has their path of, I knew from a very young age that I was going to be a healer. Like it's something profound that's just in them. First, I don't know if it's the best idea having an 8-year-old make career decisions for you. So my 8-year-old self, I was probably torn between cowboy, fireman, and dinosaur. So if my 8-year-old self had followed that, I wouldn't have ended up on this path. But so I made the decision rather late. I was actually studying abroad in Jerusalem at the time, which, if you've never been, can have a profound effect on the soul. So that's the other thing that happened to me, is it gave me a little perspective. I really didn't have much of a path, and it showed me that I should maybe take my life's trajectory a little more seriously. And that was the other reason for choosing medicine. That was really the main reason for choosing medicine. That's what set me on this path. So it was a late decider, didn't decide until junior year in college, which meant I couldn't apply straight away, had to fulfill some requirements, and then applied and thankfully made it in.
Tell me what really clinched it for you with deciding that you were going to be a doctor. I mean, it sounds like you like the sciences, you like the quantitative subjects. What was it that was the turning point where you said, "Yep, I'm going to really be serious about this. That's what I'm going to do"?
Yeah, so part of it was just being in Jerusalem and wanting to have some importance to what I do, and to I knew I was strong academically, so I was thinking, use my powers for good. Not that I'm some profound academic. Actually, quite the opposite. It's not like I'm a prolific publisher of papers or something like that. But yeah, I decided I wanted my life to have some positive trajectory rather than just being focused on what a lot of people that at Penn at the time were studying, which is going into investment banking. I graduated in 2001, which is before the dot-com bubble. So, people were making hand over fist in investment banking, and then that all just evaporated. So that was the path that everybody seemed. They were either consultants or investment bankers. So I figured I would be in some like biomedical consulting field. Great, using the sciences, but really business, and then decided that, I wanted something a little more important. But the other thing was that I didn't really have a path. And so that gave me a path. It sounds like a little bit like a cop-out, right? Like, well, I'm going to be a doctor because what else am I going to do? Right? But that's kind of what happened too, right? I didn't have some profound path. It was more like, I don't know, I'm good at sciencey stuff, so doctor sounds reasonable. And so there it happened. It wasn't anything profound. It was quite the opposite.
And so you moved to the warmer climes of SUNY Buffalo.
Yeah. So, yep. So that also, I was a little arrogant in my applications, and that I really only applied to top schools and the SUNY schools. And I was lucky to get into SUNY Buffalo. Right. So it turns out my sights were a little too high, and I ended up getting into SUNY Buffalo. And if I'm remembering correctly, off the wait list. So, made it into medical. Yes, definitely off the wait list. Made it into medical school by the skin of my teeth. And I had taken a year off. I worked for a year between college and medical school, what sounds like a very glamorous life, but wasn't. I was a bartender and a personal trainer, and I taught Kaplan MCAT classes. So I was a little delayed in my application because I had to fulfill some requirements. So I had to take that year off. But taking that year off made me take academics a lot more seriously. So that first year, I just really put my nose to the grindstone and did very well. I took my foot off the gas a little bit after that, but I couldn't take it very much off the gas, and have ended up matching into otolaryngology because it was, it's a very competitive specialty, and it has become much more competitive since. I mean, the competition just keeps growing. But I think I'm getting ahead of things in terms of where you're taking the interview.
Tell me how it was that you came to think about otolaryngology. What, when you were a medical student and you started thinking, was it in your MS2 year that you started to think about what you wanted to do, or was it earlier than that?
Um, no, it was actually the second year. It was brought to my attention by one of my closest friends, still remains one of my closest friends to this day, and is actually one of my partners because we both ended up going into otolaryngology. He said, "You should check this out. It looks pretty cool." Um, because and the thing that we both really liked about it is we do a lot of interesting things that are pretty varied. So as an otolaryngologist, we do a lot of office procedures. We do things that are pretty minimally invasive, but can have a big impact. There are subspecialties within otolaryngology that are more, say, maximally invasive, like head and neck cancer, where you're really doing big, heroic surgeries. But a lot of the stuff we do is, taking out tonsils and adenoids, septums, sinus surgeries, vocal cord surgery, neck masses, more benign neck masses, malignant neck masses. Now you're talking about a neck dissection, which is um, interestingly, you kind of open up the neck like a book. And then one of the things that I found remarkable about this specialty is you can do that and then you sew it back together and it looks the same. So you have someone in the operating room who looks just so different in the middle of an operation. And then by the end of the operation, they're just, back to the person that they were before, less some lymph nodes. So he introduced me to that and the variety of what we treat. We can treat a 4-day-old for tongue tie, maybe a 1-month-old for malacia, and maybe a 90-year-old who's having dizziness or swallowing difficulties. So the age range is huge. The pathology is very different. And then once you decide that you want to go into ENT, something I didn't realize but now do, is the type of practice that you can have varies really widely. You can be in private practice like I am and see all of those different varieties of problems, or you can go into academics and become a super specialist and just do sinus problems, or just do head and neck cancer, or just do voice and swallowing. And then if you're at the academic center versus the community, the complexity of the stuff that you see is very different. So if you want to see those uber complicated patients, then, you're at an academic center. So, the one thing that I think medical students don't realize is that, when you've chosen your specialty, the variety of practice within that specialty can still be huge. The other thing that I didn't realize is how different my life would be from that of a resident. Now I know work hours are very different, responsibilities are very different, but the type of pathology that I see as a generalist out in the community is very different from the stuff that I was seeing in the academic center at Georgetown and Washington Hospital Center.
So how did you make your choice?
You mean to do ENT and not?
Yeah.
Well, so I still liked working with kids. And so I did. So my path was at that point was pediatrics. I was still going to be a pediatric cardiologist. Pediatrics, that was the way to go. And we had our elective rotation. My first choice elective was ophthalmology because eyeballs grossed me out. Eyeballs still gross me out, and I don't understand how someone can have cataract surgery and be looking at the doctor while they're operating on their eye. So what I didn't want to do as a pediatrician is see a kid with an eye injury and then end up turning all pale and ashy and passing out on my patient. So I wanted to get over the heebie-jeebies. So I was going to do an ophtho rotation and then get over it, right? I got my second choice, and my second choice was ENT. And I remember seeing a kid, this little 2-year-old, who was now it doesn't make sense why he was admitted to the hospital, but maybe he was, maybe he wasn't. Maybe I'm just conflating some memories. But I just remember this kid trying to eat soup. And what he would do is he would take a couple deep breaths and then hold his breath, put the soup in his mouth, quickly swallow, and then try and catch his breath again. Well, why was he doing that? Well, he was doing that because he couldn't breathe through his nose. He had big adenoids. And so they did an adenoidectomy. And the next day, kid was eaten. No problem. It was nothing. And to see the recovery from the adenoidectomy, it's a really relatively easy recovery. So this minor intervention completely changed this kid's life. I thought that was incredible. And so that also, my friend, who's, like I said, is now my partner, also an ENT, had planted the seed in my head that this was an interesting specialty, but hadn't really bought that much into it. But then when I did my rotation, I really fell in love with it. I also had a great mentor, and I think medical students, underestimate the importance of a mentor, because they can help guide you through it. And so having someone that can be on the other side of that and help you through it and maybe make some phone calls and is tremendously important. So if you can find someone in the field of your choosing who knows people, then glom onto that person and do not let them go. So I was lucky to have, and her name's Linda Brodsky. Unfortunately, she passed away a few years ago, but I am forever indebted to her, actually, as is my partner, because we both had her as a mentor.
And she was one of the attendings on your rotation?
She's a pediatric otolaryngologist. So yeah, she was actually the chief of the department of ENT at the Children's Hospital. There were 4 other ENTs at the hospital. She was well known nationally. And very well connected, and just a great mentor. Like, she took us under her wing, helped us with research, and helped us get our research presented. So we were able to do poster presentations and podium presentations, and never would have thought or known how to do that if she hadn't taken us under her wing.
You are listening to Medical Murmurs. If you enjoy this podcast, don't forget to review us on iTunes and other forums. You can also visit medicalmurmurs.com and sign up to hear about new episodes.
Do you see many people with Meniere's disease? Or does that tend to go more to neuro?
No. I would hope that's us. No, we manage Meniere's disease.
Can you think of a patient who's got Meniere's? Because that's certainly someone you would have a long-term relationship. And I wonder if you could walk me through the first time you saw them and sort of, what the impact was and how things developed.
Yeah. So I had this one patient who came in and she had ear fullness. And that was her only complaint, ear fullness. And it would wax and it would wane, and it was only one side. And her hearing test was normal, and her exam was normal. And we looked at the eustachian tubes, and that was normal, and everything was normal. And yet, every so often, she'd have these exacerbations of ear fullness, and she'd come in and be evaluated. I sent her to other people more specialized than me, and nothing really came about. And then later on, she ended up she came in and she had hearing loss when it happened, right? We checked her hearing again, and now suddenly there's a drop in hearing. Oh, okay. This gives us suspicions. So for those who don't know what Meniere's disease is, it is the symptom constellation is classically intermittent episodes lasting generally for hours of vertigo. And so just so we're all on the same page with vertigo is defined as the subjective sensation of room spinning. Vertigo is not a diagnosis. Vertigo is a symptom. So it's room spinning, ear fullness, a roaring sound in your ear, and low frequency hearing loss. And if you have all of those symptoms, you have Meniere's disease. And one of my mentors used to say, if you're looking for patients that have all of those symptoms, you're never, ever going to diagnose Meniere's disease. And so this is kind of a case like that. So ear fullness, but no other, hard to figure out what's going on, impossible to figure out. So then hearing loss, and then later on vertigo, and then the diagnosis showed itself. Worked up with MRIs and all sorts of things like that. And the way that Meniere's is treated is with a low salt diet and avoiding certain things that trigger Meniere's, and a diuretic, and then sometimes we'll give periodic steroids, and sometimes we'll even inject steroid into the affected ear. So we actually make 2 holes in the eardrum. One is to put the steroids in, and the other is to a vent to let the air out, in order for the steroids to diffuse into the inner ear. and stop the Meniere's attack. So this person who had this such a, it was a symptom that was just bothering her so much, but we could never come up with an answer. It just took a while, and then eventually it presented itself, and now she's under management for that.
And what was the impact on her life of her symptoms before you got them under control?
Well, so we got them really quickly under control, because it wasn't like, sometimes people will suffer for years before either they end up going to the right place, right? They end up going to an otolaryngologist for it. But because she had been under our care for a while to begin with, as soon as something happened, she came in and we were able to get things under control. But anyone with Meniere's, her included, they kind of have to live in fear that they're going to end up with a Meniere's attack, and suddenly just the room is going to start spinning. I had a patient recently also with Meniere's, and he's been a patient of mine for a long time, and he's been on diuretics, and he hasn't had an attack in a very long time. And eventually Meniere's tends to burn itself out. And I said, why don't we try decreasing your diuretic? Why don't we maybe try stopping it completely eventually? He said, no, I'm good. I'm not having any side effects. I'm not having any attacks. Let's just leave this alone. It's working. Let's leave it alone. Okay. Just, follow up with me periodically. We'll check in. We'll do a hearing test. We'll check your balance, make sure everything's okay. But, effectively, this individual is on autopilot. He knows what his triggers are. He avoids those foods. He's very good about it. Circumstantially, he's lost a ton of weight because he's so strict about his diet. Oh, because he lives in fear, because these attacks can be so debilitating. So sometimes the best intervention is not intervention. So sometimes you'll see a patient who has sinus issues. And when someone comes in with sinus issues, it's really important that you take a good history, right? Fine. We say that about everyone. That's first day of medical school. It's all in the history, right? Take a good history. Yeah, but so one, I would say, like, the word congestion can be very dangerous, because the patient will come in and he'll say, I'm very congested, and I've had 2 sinus surgeries, and I'm still congested. So what do you mean by congested? Because if a patient says to you that they're congested, how do you interpret that? Describe the pain to me. It just hurts. It hurts. Just fix me. Come on. Yeah. So when they're pointing to their face, it really breaks down into, it could mean 3 different things. It could mean that their nose is blocked and they can't breathe, right? Large adenoids, nasal polyps, deviated septum, God forbid a nasal tumor, right? So that's what congested means to me when I say I'm congested, because, if you look at the pharmaceuticals, a decongestant is something that will unblock your nose, right? Afrin is a topical decongestant, so it makes it so that you can breathe again. So that's one definition of congestion. That's the one that I use. That's not what this gentleman meant. And then there's extra mucus in your nose. So you got to blow your nose a lot. So you're blowing your nose and you're blowing your nose and you're blowing your nose. Why are you blowing your nose so much? Well, there's congestion in it. And for those who treat patients from the Caribbean, that's a cold for them, meaning like I blew some cold out into the tissue, right? So to understand, you got to understand everyone's vernacular. And if you don't, you got to figure it out. You got to ask them. So those are 2 types of congestion. Then there's the third one where they're actually pointing to their face. They're pointing to their frontal sinuses. They're pointing to their maxillary sinuses, and they're saying, I'm congested, right? And that's where it gets a little hairy, because that's what this gentleman said to me. I've had 2 sinus surgeries and I'm still congested. And so, I looked in his nose. I put a camera up his nose. He had sinus surgery. Sinuses were wide open. Whoever had done his sinus surgery had done an excellent job, right? They're nice and open. I can see there's nice, healthy mucosa lining the sinuses. They hadn't taken out too much. They hadn't caused any scarring. Everything looked great. A very professional job. Fantastic. Well, then why am I still congested? And this is where it gets a little tricky, right? Well, when are you congested? Well, whenever the weather changes. That's kind of a tricky thing for someone to say because the weather is always changing. But really what he was getting at was whenever there's crappy weather, right? Whenever there's a storm front coming in, that's where you get. So he's like, the barometric pressure changes, and that's why when my sinuses get congested. Okay, so maybe it has something to do with the barometric pressure change. Well, that wouldn't really make sense because the sinuses are wide open. I can see into them. There's no difference between the ambient pressure and the pressure in his sinuses. So what was it that he was talking about? So we really dug into it. And yeah, whenever there's crappy weather, he gets like pressure in his sinuses. And so, what I said is, come in when it's happening. So he came in, I scoped him again, still normal exam, nice wide open sinuses. We even got a CAT scan to make sure it was normal. It wasn't normal. So I gave him some Imitrex and I said, the next time you feel like it's about to happen, I want you to take this. And 2 hours later, it's not working for you. Take a second one. And then I don't need you to follow up. I just want you to call me. So he called me and he told me what happened, and I sent him to one of my colleagues, the neurologist, and we diagnosed him he was diagnosed with migraines. So this person had 2 sinus surgeries for congestion, and it was just ultimately, the original doctor was treating a problem, and I'd seen his old CAT scans, and there was some thickening of the lining of the sinuses. This was not a totally normal CAT scan. So, you could think of it in one direction as like, this person has pressure because there's abnormalities in the sinuses. We're going to open them up. We're going to let the airflow go through. But as it turns out, this individual was actually having a migraine that presented as facial pain or facial pressure rather. And it's important to make the distinction because if you asked him, he said, no, it doesn't hurt. It doesn't hurt. It's just pressure.
So really 4 different things there for the wood congestion. One being a blockage to airflow, another being, discharge or rhinorrhea, another being pressure, another being pain.
Yeah.
So what would you say in general are the highs and the lows of a life in ear, nose, and throat medicine?
the highs and the lows. So, the highs are the satisfaction of the patient that leaves and said, I am going to send all of my friends to you. I am going to speak. This was so great. Or the patient says, I've been suffering for so long and you finally figured out what's going on. Right. Or, those are the really where you get that satisfaction, right? You did good today. This patient is now better and will continue to be better because of what you did. Or even some of the highs are like my regulars, the ones that come in just, because they get wax impactions. There's something wrong. Maybe they got an eczema in their ear canal or they have a small ear canal. So I just, chat them up. Hey, maybe the college student, what are you studying these days? You're still with that girl that you were with before, right? Like, how's that relationship going? You're just chatting it up. It's nice. It's fun. It's casual. It's great. And the lows are the patients that aren't doing so well, and the ones that you might not be able to help, and you got to send them on to colleagues with more expertise than you, knowing that they might not do well, right? And having to be that bearer of bad news. And I think it's important to have perspective on that, in that, I don't really mind that much being that bearer of bad news because I know that I'm going to do it to the best of my ability, right? Like, someone's got to break this news to this patient. That's how I spin it to myself. Someone's got to break this news to this patient. As much as I'm not enjoying this, I know that I'm going to do it to the best of my ability, and I'm willing to accept that responsibility.
What's an example of that kind of news?
Well, like head and neck cancer, right? Like you diagnose someone, you see they come in with a couple months of a sore throat, and you stick a camera down their throat, and you see this base of tongue cancer. Or they present with a neck mass, and then you find that base of tongue cancer. and you diagnose it, and it's already metastasized to their neck. And because I in my practice, I don't really do management of oncologic patients, I send them to the academic centers. Really, I think that's a better place for them. But yeah, cancer. It's what you would think when you're breaking bad news. What are some other diagnoses that I might make that are bad? Like not everybody. So there's something called sudden sensorineural hearing loss, where you just suddenly lose hearing. It could be in the middle of the day, could be you wake up in the morning and your ear is clogged and you think it's wax, you think it's fluid, you think it's something. The sooner you get to the doctor, the better your outcome is. Although, there's some thought that might be a little bit of lead time bias that's skewing our data. And we'll put those patients on steroids. I have someone that came in recently and she loves music. I think she plays the bass in a band. I think they perform at weddings. And she came in and she thought it was just going to be wax. I was going to take it out and she'd go back to what she was doing. But no, she had lost some hearing. So I put her on high-dose steroids, which is how this is treated. Checked back in a week, did a hearing test. She got a little bit of hearing back. So I gave her another dose of steroids, checked in a week later. The needle hadn't moved at all on her hearing. And so we tried some middle ear injections. So kind of like Meniere, same idea. You put steroids through the eardrum into the middle ear space. We tried that. Didn't move her hearing. And the frustrating thing about that is that, her hearing wasn't terrible, but the thing that was really affected is something called her speech discrimination. So her ability to understand language. So when our audiologists, they put you in the soundproof booth, and one of the things they do is they read you a list of 25 different words, and you got to repeat them back one at a time. It's not like you have to memorize the words. And so I think she got like 25% of them right. I mean, you can't write 20 if it's going to be an even number, but you get the idea. It was a low number. So it really affected her speech discrimination. And that's like tantamount to having a conversation with someone that has one bar on their cell phone. It doesn't matter how loud you make it. So she's not even a hearing aid candidate, right? She's devastated by this news, devastated. So, she might be a candidate for a cochlear implant, but, she effectively lost her hearing, and all she's getting through that ear is noise. So,
is it both ears?
No, one ear. So yes, she still has one good ear.
How did she take the news?
In stride, because the thing is, there was some time for it to sink in, right? She came in, she found out, she lost her hearing, she might get it back. Week later, you still might get it back. Week later, you probably won't, but there's a chance you might get it back. And then, and then it's so the fact that she was able to ease into the news made it much easier for her.
You are listening to Medical Murmurs.
You brought up before breaking down or deconstructing the OTC meds. And I was wondering, I see some general practitioners and emergency physicians using antihistamines for people that have viral syndromes. And, I haven't seen any evidence of the efficaciousness of that. I'm wondering, when do you actually use each of the component medications that are OTC?
All right, so I'll give you the spiel.
Okay.
So the spiel is, if you're having pain, whether it's throat pain or sinus pain, then you treat that with a pain medicine, right? And that's going to be one of your nonsteroidals, like ibuprofen or naproxen. All right, if you're having congestion, and congestion being defined as not being able to breathe out of your nose, right? Not being defined as facial pressure, because as we discussed before, facial pressure, form of pain, treat that with your ibuprofen or your naproxen. So if you're having nasal obstruction, then pseudoephedrine or oxymetazoline nasal spray, or breathe right strips, or some combination thereof. Now, pseudoephedrine, as I'm sure you're aware, is with the pharmacists. It does not require a prescription, but you do have to sign for it and show them your license so that you don't buy a lot of it and cook it into crystal meth. So pseudoephedrine. But who can't use pseudoephedrine? Well, older men, if they have a prostate problem, and most older men do have at least the beginnings of a prostate problem, because it can put you into urinary retention, but it also can drive your blood pressure, which I'm sure you also know. So those are the limitations of that medication. You also don't want to take it before bed because it's a bit of an upper, right? Because it's a stimulant. It increases your heart rate, increases your blood pressure. Also, if you have any type of arrhythmia, it's a bad idea. Consult your doctor before taking the medication. Please don't mistake this for medical advice. I am not your doctor, and what you're listening to right now is not a doctor-patient relationship. Sorry, there are lawyers out there, and they're after us. Okay. So then there's oxymetazoline, which is Afrin, which is great, only it can lead to dependence, but it's great for colds because colds last a couple of days. So use that so you can breathe better through your nose. Your life will be a whole lot better. And then breathe right strips work for some noses, but not others. So that's for congestion and drainage. And then for cough, I'm a firm believer that nothing works for cough unless you have undiagnosed asthma, which I see all the time because people think, well, when I lie down, my cough gets worse and that's because of my postnasal drip. No, it's not. It's just because nobody diagnosed your asthma and you need to be using an inhaler. But other than that, sucking candies and voice rest are what I recommend for cough. I do not recommend Tessalon or Delsym or any of those other medications. But to what you were saying with the cold medicines, so I recommend Benadryl. Why? Because then at least you'll sleep. Because there's nothing worse. The only thing that's worse than being sick is being sick and tired. So at least take some Benadryl. But the other thing about Benadryl and the antihistamines in general is they do, quote, dry you up a little because they do have some weak anticholinergic effects. So it's not the antihistamine effect because when you have a cold, your mast cells are not blowing up. There's not some massive release of histamine. No, but if there are some anticholinergic effects, then that can dry up your mucosa a little bit, kind of like an ipratropium nasal spray might do, only not as effectively. So yeah, so that's the thing. Pain, ibuprofen, naproxen, stuffiness, Afrin, Sudafed, breathe right strips, cough, nothing, and then Benadryl for sleep. That's my deconstructed cold remedy.
Thank you so much for taking the time to talk to me. I loved the OTC spiel. I loved hearing about your case with Meniere's. It was just fascinating. Thank you very much.
Oh, it was my pleasure. My pleasure.
Take care.
This is Medical Murmurs. If you're a medical student or just interested in medical careers, there is another episode with the same guest, where we focus on career questions such as how best to get into a specialty and develop a career. It's called Medical Murmurs Medical Student Edition. Check it out.